Next up in an emergency medical response course, we're going to talk about circulate, ventilate, oxygenate. I want to remind you where we are, give you some context here. Our plan to help Mrs. Smith is to respond promptly and safely. Doesn't do any good if we get there too late. Doesn't do any good if we don't get there because we get in a crash or we cause a bunch of other problems. We need to approach the scene and enter efficiently and safely. We always want to be nice. We always want to be safe, and we really need to be good. And this is another of the lessons in helping you learn to be good. And when the medics make it there, we're going to help the medics help the Smiths. So we're looking at the second step in our assessment and treatment 5-step plan. Is it a code? If it is, let's work a code. If it's not a code, which it usually isn't, then let's talk about circulate, ventilate, oxygenate, and then in a little bit we'll do a lesson about finding things and fixing them if we can in a rapid exam sort of format. We're going to record some vitals and record some history. Later on in the EMT section, then we'll talk about a secondary assessment of focused history and physical, talk about reassessment. We add some more steps to this whole assessment process. But for the EMRs in our quick, first and fast, let's get you ready to go in 5 sessions. Here's the deal. We need you to figure out if it's a code. If it's not a code, which it usually isn't, deal with circulation, ventilation, oxygenation. If you get nothing done but that, you've made a difference for Mrs. Smith. Then we want you to find and fix things, record some vitals, and record some history. So, circulate, ventilate, oxygenate. What's the circulate about? Well, we need to talk about peripheral pulse and central pulse. So the idea here is that as circulation starts to get bad, it starts to degrade, then the peripheral pulses go away and the central pulses remain. And so if you can check a radial pulse, a peripheral pulse, and you can find that it is not there, you can say that the blood pressure is bad. You can't really say what number it is, but it doesn't matter. Bad pressure is a bad pressure, whether that number is 50, 60, 70, 80 systolic, who knows, who cares. We're looking for a qualitative measure here. If there's no radial pulse, we have a bad blood pressure. A central pulse would be the carotid in the neck or the femoral, or femoral, some people say, and I think both are right. The carotid or femoral pulse, the femoral pulse in the groin, those are central pulses. Those are near the central circulation. When those go away, it's called a code. And so we have to do CPR, it's cardiac arrest. When you're evaluating pulses, we look for their rate and their strength. So a fast heart rate, if you remember, was a sign of hypoxia and shock. And then we also are evaluating, is that pulse even there and how strong is it? We're estimating blood pressure. We're evaluating the quality of that peripheral pulse rather than taking the time, which the patient doesn't have for us to take in some cases, to get the blood pressure cuff and actually measure it. Because you know what, a bad pressure is a bad pressure, and we need to jump into some treatment there rather than waste time measuring how bad it really is. Circulate, ventilate, oxygenate. Here's the ventilate part. Here's a quick and easy one. If they're not breathing 8 times a minute, they need you to ventilate them. If they're breathing more than 28 times a minute, the National Registry, which you will take the National Registry test for your EMT, the National Registry really wants you to ventilate patients that are breathing more than 28 times a minute. We want you to attempt to ventilate those patients. It may be that the cause of their rapid breathing doesn't really require ventilation. It may just be hyperventilating or something like that. But they also may be too conscious. They may not let you ventilate them. But at any rate, if you were to start learning less than 8 or more than 28, you better ventilate. That would be a nice little saying for you to know. So we're looking at evaluating ventilation. We want to know about the rate, the effort, and depth of breathing. RED, rate, effort, and depth. The rate of their breathing, less than 8 or more than 28, we need to ventilate. In between there, they're still maybe having trouble, and we need to deal with that. Their effort of breathing. So how do you tell if somebody's working hard to breathe? Well, you just look at them, right? And you just kind of know. And Mrs. Smith knows when Mr. Smith's having trouble breathing. She can look at him and say, look, he looks like he's having trouble breathing. We want you to be a little more precise with that. We want you to look for accessory muscles of breathing. Now, the diaphragm is the primary muscle of breathing. But the diaphragm gets help from accessory muscles. Muscles in the neck, muscles in the chest in between the ribs, called the intercostals, and muscles in the belly. So look at somebody who's short of breath, having trouble breathing, and they're using their neck and they're using their belly muscles. And if you were to look at their chest, you would see the muscles between the ribs working, the accessory muscles of breathing. That's one thing that would show you they have an increased effort, an increased work of breathing. The next thing is a long expiratory phase. It takes them a long time to exhale. So if you just take a breath in normally, that took some energy to inhale, and you just relax, and you naturally, passively, without using any energy, with no work, you exhale. And if you look at the timing and just watch somebody breathe, especially if they don't know you're watching them, they will inhale for a count, and they'll exhale for 2 or 3 counts. But if they're inhaling for a count and they're exhaling for 4, 5, 6 counts, if it looks like they're having a long, hard time forcing air out, they have a prolonged expiratory phase, then those folks have an increased work of breathing. And believe it or not, people can get too tired to breathe anymore. The last thing on our list of 3 things to check on effort is pursed lip breathing. We can show you that in class. You've probably seen that and didn't really realize what you were looking at with somebody who's short of breath. But they are providing some back pressure to their lungs, and they're using pursed lips when they breathe. They're not just breathing, exhaling passively. They're actually working to push some air out. So, on ventilation, rate, effort, and depth, RED, 3 things. The rate of breathing, less than 8, more than 28, probably ought to ventilate. On effort, we're looking for accessory muscles, prolonged expiratory phase, working to exhale, in essence, and pursed lips fit into that. And then you also want to evaluate the depth of breathing. And so you'll need to start looking at people as they breathe and realizing that no one breathes in as deeply as they can. They breathe in a normal depth, and we need to have you start getting used to that. So maybe a homework assignment should be to go to Walmart and watch people breathe, or go to Golden Corral and watch people breathe. You'll see some folks there that can't breathe. Just saying. Now start looking at people's depth of breathing and realize that normal depth is not their maximum depth. It's a whole lot less than that. So we have circulate, ventilate, oxygenate, CVO. Circulate, we talked about checking peripheral pulses, blood pressures, that sort of thing. Ventilate, we talked about rate, effort, and depth. And on oxygenate, we're looking to see, is this patient cyanotic? Do they have blue lips, blue face, blue fingernails? Cyanosis is bad. It's normal in some folks with advanced lung disease. It's normal for them that they have it every day. It's not normal. It's bad, but they have it every day. But a lot of people don't have that, and so cyanosis is one thing to look at. So we know cyanosis is bad. We know oxygen is good up to a point, but too much of any good thing is a bad thing. So ice cream is a good thing, but if you eat a gallon of it, that's not a good thing. So what we're looking for is an oxygen level that is normal but not completely over the top, maxed out and crazy. How do you measure someone's oxygen level? Pulse oximetry. You put a pulse oximeter or a pulse ox clips on their finger. You get an O2 saturation, not a stat, an O2 sat. And that O2 saturation, the goal for a person without lung disease is to be 94 to 99%. Ice cream is good. A gallon of it is not good. We don't need 100%. We can explain to you why if you really want to know, but really at this point, for the EMR portion, we're going fast here. So let's just accept that. Just trust us. 94 to 99, that's the goal. And so you put the pulse ox on, and it's reading the oxygen level in the finger. So that means the finger has to have good circulation. If your finger's cold, you're going to have a lower oxygen saturation reading for the finger, and we want you to be aware of that and not start believing that your patient is hypoxic. He just has a cold finger. If that patient's blood pressure is poor, then their perfusion to their finger is going to be poor, which means that their oxygen saturation is going to read poor, even though it's not really, maybe. So that finger probe needs to sit still. They're really pretty forgiving for pulse ox. Now we have on the fire district carbon monoxide oximetry, and that probe is very, very finicky. Has to be still, has to be on the ring finger, non-dominant hand, has to be covered with a towel. Real picky. Pulse ox, easy. People even have these at home. And so it just needs to be on the finger. Finger needs to be still. I wouldn't put the blood pressure cuff on that same arm, or you're going to be reducing blood flow to the pulse oximeter's finger. Tourniquet, same thing for IVs. The medics are there doing an IV, and you've got the pulse ox below the tourniquet, you're going to get bad pulse ox readings. And so low readings can be from cold fingers, poor blood flow, whether from a BP cuff, a tourniquet, or just bad blood pressure, or the probe moving around. You can get low readings. And then also if they have carbon monoxide exposure, which some people do a pack a day because cigarette smoke is a source of carbon monoxide. So maybe they have some carbon monoxide in their body, and that is causing the reading to be high. Now, it's not going to be way, way high for the smoker, but the person who has carbon monoxide exposure from a structure fire or, say, a suicide attempt using a vehicle, then they may have a very high pulse ox reading, and actually they are very, very hypoxic. That's because of this, real quick. Pulse oximeters read shades of red. Carbon monoxide makes blood redder. Oxygen also makes blood red. So if carbon monoxide is present, the blood looks red to the pulse oximeter. Pulse oximeter reports a high reading, and you need to be sure that you're using your sense here, and that you're making sure that that piece of data, that O2 sat, is good, valid data. Don't make decisions on bad data. Bad decisions come from bad data. So O2 sat gold 94.99. We'll talk a lot more about it, but circulate, ventilate, oxygenate, and that's the next step in our assessment plan.